sorry, there are some seminar on basic chapter hemostasis and bleeding. Topic into 3 parts, and there are 3 presenters. Dr. Diptaman Nundi is from first year PGT at Dr. Singh, who is in SSK Hospital, first year junior resident. So Diptaman will speak on physiology of bleeding and hemostasis. Okay, Diptaman, you can share your screen and start.
मेरे चार्जर Sir, are the slides visible?
Yes, yes, it is visible, Dr. Diptaman.
Good morning, sir, other seniors and my dear colleagues. I am Dr. Diptaman Nandi. I am going to present the physiology of bleeding and coagulation. Blood is a necessary component of the human body, and the loss of this fluid may be life-threatening. Blood is generated via hematopoiesis and ultimately becomes the delivery method for oxygen to the tissues and cells. The human body protects against loss of blood through the clotting mechanism. Bleeding are generally 3 types in our scenario. Namely spontaneous, traumatic, and post-surgical. Spontaneous bleeding are generally noted. They are related to the complication of anticoagulant therapy like heparin therapy or warfarin therapy. Traumatic bleeding happens in case of any injury that can cause traumatic bleeding. And post-surgical bleeding may be the result of ineffective hematopoiesis, consumptive coagulopathy, fibrinolysis, and etc. Now we come to hemostasis. Hemostasis is a complex process whose function is to limit blood loss from an injured vessel. Hemostatic mechanism can be divided into 2 stages. First is primary hemostasis, which is formation of a weak platelet plug, and another one is secondary hemostasis, which is stabilizing the weak platelet plug into a clot by the fibrin network. Primary hemostasis is the formation of a weak platelet plug, which is achieved in 4 phases, namely vasoconstriction, platelet plug formation, fibrin formation, and fibrinolysis. Now we come to the biology of hemostasis. This is a pictorial presentation showing 4 phases or 4 processes in hemostasis. Number 1 is vascular phase, which is related to vasoconstriction mainly. And the next phase is platelet phase, or here the platelets aggregation occurs. And third phase is the coagulation phase, which leads to the formation of a clot. And the final phase is the fibrinolysis phase, which leads to the clot destruction process. Next, there is schematic activation and thrombus functioning, one pictorial presentation. This is the pictorial presentation showing that vascular injury, which leads to two types: platelet hemostatic function and vasoconstriction. Then combination of this leads to subendothelial collagen, which again forwards to platelet adhesion secretion, which is again acted upon by ADP, serotonin, calcium ions, and fibrinogen. And with this chemical mechanism or reactions, it leads to formation of an platelet aggregation secretion, which is the previous is reversible, but after this process, which is activated by ADP, serotonin, calcium ions, and again fibrinogen, this is an irreversible procedure which leads to final formation of a platelet aggregation. And this is also a part of the intrinsic and extrinsic coagulation pathway, which will be shown later. And this whole procedure is activated by coagulation activation via tissue factor, that is factor 7A, which again is followed by factor 9A, factor 10A complexes on activated platelets. And this finally leads to reaction of thrombin and fibrinogen, which again finally leads to formation of platelet fibrin thrombus. Now we come to secondary hemostasis. Secondary hemostasis involves the clotting factors acting in a cascade to ultimately stabilize the weak platelet plug. This weak platelet plug is already formed in the primary hemostasis phase. Now this for proper hemostasis, this secondary hemostasis procedure is necessary, which will stabilize this clot or platelet plug. This is accomplished by completing 3 tasks. Namely, number 1 is triggering the activation of clotting factors or coagulation factors. Second one is conversion of prothrombin to thrombin. And finally, the conversion of fibrinogen to fibrin. These tasks are accomplished initially by one of 2 pathways, namely the extrinsic and intrinsic pathway, which finally converge at the activation of factor 10 and then complete their task by the common pathway. And all of these procedures require the action of calcium ions. Now, this is the pictorial presentation of the intrinsic, extrinsic, and common pathway. I am explaining in the next slides this pathway. This is for the visual presentation. So, for a slide, yes, I can make it. Now, for the extrinsic pathway, the extrinsic pathway includes tissue factor and factor 7. It is initiated when tissue factor binds to factor 7, activating factor 7 to factor 7A, which leads to formation of tissue factors, factor 7A complex. This complex in turn activates factor 10. It is to be noted that tissue factor and tissue factor 7A complex can also activate factor 9 of the intrinsic pathway, which is called the alternate pathway. Next, when factor X is activated to factor 10A by tissue factor and factor 7A complex, this cascade continues down the common pathway. Now, this is an intrinsic pathway. The intrinsic pathway includes Hegman factor, that is factor 12, then factor 11, factor 9, and factor 8. This process is initiated when factor 12 comes into contact with exposed subendothelial collagen and becomes activated to factor 12. Subsequently, factor 12 activates factor
non-speakers, please mute yourself. Non-speakers, please mute yourself.
Abhishek, Jais, Om.
Non-speakers, please mute yourself.
अच्छा वो सर बाहर से आते हैं क्या
once factor 10 is activated by factor 9A, factor 8A complex, the cascade continues down to the common pathway. Now, this is the final common pathway, which is initiated via the activation of factor 10A. Factor 10A combines with factor 5A and calcium on the phospholipid surfaces to create a prothrombinase complex, which ultimately activates prothrombin into thrombin. This activation of thrombin occurs via serine protease, cleaving the prothrombin. Now, this finally thrombin activates factor 13A, and 13A cross-links with fibrin, forming the final stabilized clot. So this is all about related to bleeding and hemostatics mechanism.
Dr. Sarva, you can have 5 minutes discussion on this. He has touched, but something more to be covered.
Yeah. Is he supposed to talk about applied physiology also, or is this only the physiological?
Some part should have been talked about, because other people talking of the diseases, the coagulopathy should be discussed, but basically it was just a physiology. But what I'm trying to say, you have not emphasized that we don't have spontaneous bleeding. Why? Because blood contains both. Blood contains some components which leads to coagulation. Blood contains some substance which can lyse the coagulation. So there is a balance in the body system. There is a balance between these substances which cause fibrinolysis and substances which cause coagulation. And once this balance is altered, patient have spontaneous bleeding. That is the most important part. And second is, as you said, the bleeding can be of different types. And this bleeding is controlled by body's own mechanism. And when the own mechanism fails, there is a transition of the vessel. Nothing will work. Nothing will work. The platelet plaque cannot form. And the platelet plaque formation is not the only factor. Platelet is a non-nucleated cell, but it has a lot of component inside. What we are talking of, the serotonin, ADP, calcium, these are all secreted by the platelets. And this creates this formation of a good platelet plaque. Okay. Dr. Sarfaraj, anything to add?
No, I think I would have liked to hear a little bit about how this is useful in our surgical trauma. What are the things that happen in surgical trauma? So when you're operating, how do these vasoconstriction, then the clotting factors, how do they help us in minimizing the bleed that we have? How does pressure and packing help us? So those things, basically. Some applied physiology.
Yes. So you understand what Dr. Bega, suppose you are operating, and while operating a bleed, what do? You just press. And how does the pressure helps in hemostasis? What is the mechanism? When you press, what happens?
Yes.
We have a lot of things to control this bleed. Pressing, crushing with the hemostatic forceps, then ultimately coagulating or ligate. So these are the situations you manage your bleeding during surgery. But how does the pressure simply helps?
Yes.
What happens on pressure?
What is the physiology behind?
What happens on pressure? You are squeezing the vessel. As you said, there is vasoconstriction. As you squeeze the vessel, it is mimicking the vasoconstriction. And the point of breach, if you keep the pressure for some period of time, maybe 1 or 2 minutes,
Coagulation
first is platelet plaque. First is a platelet adhesion and platelet plaque formation. This is a minor bleed will be controlled by simple pressure. Okay, so this is the most important part, that this mechanism is helping your surgical procedure. Okay, if this mechanism was not there, a situation where a simple platelet plaque and this clot can manage. And you see, once a clot is formed, the clot could have exacerbated. That means clot is formed and it is forming more and occluding the vessel. What will happen? This happens in patients who are thrombotic. This happens.
Hyperexaggeration of thrombosis, hyperthrombosis.
So what is the ill effect? If you don't have the balance, between this coagulation being stopping at one point and not progressing further, suppose it is progressing further, what is going to happen?
So it will lead to irregularity of blood flow to vital organs.
Yes, it will cause occlusion of the vessel and lead to infarction.
Hypoxia, infarction, these all things.
So that there comes a balance. You should have talked up a little about fibrinolysis. Once a clot is formed, this clot has to again lyse. How the clot is then lysed? The clot cannot stay on the surface of the vessel. The clot has to undergo lysis. How lysis occurs? Body has its own mechanism of lysing the clot. What is there in the system? You have plasminogen.
It lyses the clot.
Plasminogen does not lyse. Plasminogen is converted to plasmin. So body has its own mechanism where it can lyse this formed clot.
Anticoagulation.
Yes.
Yeah. So just one more point to add to all of that, which is all great, is that if you are just applying pressure and packing, and since I think you did not mention the bleeding time and the clotting time, if you wait long enough, vessels will have a physiological mechanism of platelet plug and a coagulation, because you've read BT is 3 minutes, CT is 5 minutes, 7 minutes. What does it all mean? It means the time taken for a platelet plug to form, time taken for a clot to form. And if you apply pressure for 3 to 5 minutes, all surgeons have realized that many of the bleedings can stop. And why is that happening? Because of all that you spoke, today, that is responsible. It takes time, but that is responsible for hemostasis of any hemorrhage that a surgeon can induce in a surgery. So knowing that applying pressure, waiting for long enough can minimize or stop bleeding in most cases, because all this mechanism is working in a period of time. That's all from my side.
Yeah. So you see, your part is very important to understand the subsequent two discussions. The coagulopathies, the bleeding disorders, all can be explained based on the physiology what you have talked of. That's why you are interested. That this is the basis of the underlying disease process and the basis for the therapy also. The therapy will be directed to the physiology of the hemostasis. Okay, some therapy is important, that you have got a platelet deficiency and platelet defect. Nothing is going to happen if you use something else rather than improving the platelet function. Okay, so physiology is very important. You should read a little more depth about this physiology part. Now we'll pass on to Dr. Aditi. Dr. Aditi Singh will speak on the coagulopathies and coagulation disorders in surgical practice. Aditi is there?
Yes.
Yes, sir. Good morning, sir.
Good morning. Yes,
Morning.
please. Yeah, that's good.
Good morning, respected faculties and seniors. My topic is bleeding disorder and coagulopathies. Sir, am I audible?
Yes, you are very much audible. Please.
Sir, hemostasis. It's a complex process that involves interaction between the blood vessel wall, platelets, and coagulation factors, as we saw in earlier presentation. There are certain steps of hemostasis. There is injury to the vessel wall, the early hemostatic response, platelet plugs and platelet aggregation occurs, fibrin clots form, and then lastly there is fibrinolysis. Coagulation system consists of a cascade of certain soluble enzymes, proteins, which when proteolytically cleaved and activated, each of them are capable of activating one or the more components of the cascade, endpoint being formation of fibrin. Fibrinolysis is dissolution of fibrin clot and thrombus by activating tissue thromboplasminogen activator released from the endothelial cells. Any derangement of these hemostasis process results in excessive bleeding or clotting, and this is called coagulopathy. Now, there are certain tests for hemostasis. We can do bleeding time, clotting time, prothrombin time, activated partial thromboplastin time, and platelet counts. These are the clotting factors. We can see fibrinogen, prothrombin, tissue factor, calcium ions, proaxilin, proconvertin, anti-hemophilic factor, plasma thromboplastin component, Stewart factor, plasma thromboplastin antecedent, Hagman factor, and fibrin stabilizing factor. Most of them are formed in liver cells, except some like tissue factor in tissue cells. Some are also formed in lungs and in bone marrow. They have their own pathways and functions, which we saw in earlier slide, through which they perform the process. The tests, the normal bleeding time, normal range is 1 to 6 minutes. And there are certain tests which may be abnormal, like thrombocytopenia, von Willebrand disease, abnormal platelet functions. Prothrombin time normal is 9 to 12 seconds. In the deficiency of factor 2, 5, 7, and 10, prothrombin time is increased. Activated partial thromboplastin time is 26 to 36 seconds normal, and they are deranged in deficiency of factor 2, 5, 8, 9, 10, 11, and 12. Normal platelet count is 1.5 to 4. Approx 4.4 lakhs, and they are deranged in thrombocytopenia. The classification of the bleeding and clotting disorders is bleeding disorder can be due to vascular abnormalities, and platelet disorders like platelet disorder can be further of qualitative or quantitative. Clotting disorders can be hemophilia A, hemophilia B, von Willebrand disease, vitamin K deficiency. Most of them are congenital. They can be drug-induced fibrinolytic disorders. Now, there are certain differences which we can find between the platelet disorders and the coagulation disorders. In the platelet disorders, we will find petechiae as characteristic feature. The superficial ecchymosis we can have. Usually, these are small and multiple, while in coagulation disorders, these superficial ecchymoses are large and usually solitary. We will find hematoma in case of coagulation, which is rare in platelet disorders. Hemarthrosis is again rare in platelet, but characteristic feature of coagulation disorders. There will be delayed bleeding in coagulation. Platelet disorder causes profuse bleeding from even from superficial cut and scratches. Platelet disorders are more common in female, and coagulation disorders are more in males and with a positive family history. Bleeding disorders can be classified like autoimmune due to infection cause, or structural malformations and certain other causes. Autoimmune can be allergic purpura, drug-induced purpura fulminans. Infectious could be due to septicemia, typhoid fever, diphtheria, tuberculosis, meningococcemia, smallpox fever, influenza, measles. These can be the cause of bleeding disorders. Malaria, toxoplasmosis. Structurally, hereditary hemorrhagic telangiectasia can be there. Hereditary disorders like Ehlers-Danlos syndromes and osteogenesis imperfecta can be there. Acquired connective tissue disorders includes scurvy, corticosteroid purpura, senile purpura. Other causes miscellaneous includes autoerythrocyte sensitization and related syndromes, paraproteinemias, purpura simplex, purpura in association with other skin diseases. Platelet abnormalities, which we saw earlier, like can be qualitative or quantitative. Qualitative defect is result of impaired platelet function and defective aggregation. Now, there are certain drugs which can interfere with platelet function, like aspirin, clopidogrel, prasugrel, etc. At least these drugs should be stopped 5 to 7 days before an elective procedure is performed. We can do thromboelastography with platelet mapping to check for the platelet function. Platelet dysfunction of uremia can be there, which can be corrected by dialysis. Platelet dysfunction in myeloproliferative disease improves if the platelet count can be reduced to normal by chemotherapy. Quantitative defect is result of failure of production or shortened survival or sequestration of the platelets. Now the quantitative platelet disorders can be decreased from platelet count, like include idiopathic thrombocytic thrombocytopenic purpura, also called immune thrombocytic purpura, thrombotic thrombocytopenic purpura, Wyshkoff-Aldrich syndrome, heparin-induced thrombocytopenia. In thrombocytosis, quantitative includes myeloproliferative disorders. Qualitative platelet disorders mostly congenital. They can be Glanzmann's thrombocytopenia, Bernard-Sollier syndrome. There can be storage granule abnormalities. Acquired could be drug-induced, acute or chronic leukemias, hemorrhagic thrombocythemia, myelofibrosis, or anemia. There are various terminologies in surgical contact. They can be trauma-induced. It can be called trauma-induced coagulopathy or acute coagulopathy of trauma shock or acute traumatic coagulopathy. It means the complications. The acute coagulopathy can cause complicate the surgery, and control of bleeding is difficult in such situations. If there is coagulopathy, it can be immediate on any onset. 1 out of 4 trauma patients it can be found in. First, there is acute traumatic coagulopathy. The primary endogenous coagulopathy involves there is shock, and if there is iatrogenic resuscitation associated, it will be it will present as lethal triad of hypothermia, acidosis, and the loss of iatrogenic dilution. Thank you.
Nice. Yeah.
Yes, Dr. Big. Aditi, I think you should have emphasized a little part in surgical practice. One of the very important situation is consumptive coagulopathy or disseminated intravascular coagulation. That bothers us most of the time. And there are different mechanisms for this DIC to come up. And you have to know the basic pathology underneath so that you can start treating this patient. You talked of thrombotic thrombocytopenia. That's true, but in DIC, there are a lot of factors which can lead to disseminated intravascular coagulation. One important is trauma, and then shock, and then there are some other factors, sepsis. And what happens in DIC is a consumptive coagulopathy. That means there are different sites in the vascular system where the thrombotic process is initiated, and that consumes the platelets. As a result, patient has global deficiency of platelets and may lead to bleeding. And one has to differentiate that you have a bleeding due to other reasons or is bleeding due to a consumptive coagulopathy. Because you see, once you are bleeding, you keep in mind that heparin is a treatment. If you have consumptive coagulopathy, you can diagnose consumptive coagulopathy, it is generally heparin. And heparin is anticoagulant. Patient on the phase of bleeding, you are giving heparin to these patients because we have been able to diagnose DIC. That is a basic recommend. This is a more important. You have talked of a lot of syndromes. As surgeon, we don't find these syndromes in our common practice, but we are more bothered about our traumatic coagulopathy. Traumatic coagulopathy is a very important entity, and you talked of the lethal triad. And the recent concept of resuscitation is you avoid this lethal triad. And now there is a role, even the patient has got a bleeding traumatic, there is a role for giving tranexamic acid. That is another recommendation for trauma management. Okay, so I think we can get the answer in the next speaker. Anything else, Dr. Sarfraz?
Yes. Yeah, so I totally echo the sentiments of Dr. Shah, Professor Shah. So Aditi, we would like to hear more about applied, and DIC is the most important thing that we want to hear. Other things, I think you touched upon how to deal with patients on antiplatelet, but what about patients who are cirrhotic? Cirrhotic patients have a coagulopathy. So if, let's say, a cirrhotic patient has an acute abdomen, umbilical hernia which is obstructed, or it has even the skin has given way, and you have to operate on this patient. So how would you prepare this patient? How will you take care of the problem? Yeah.
Aditi, in
Yes.
cirrhotic patient, what are the problems? One important problem in cirrhotic patient is what? Patient has splenomegaly. Patient has what? If you that is one of the important workup. If you are operating in a patient who has got liver disease, you have to work up the patient, and most of the time patient has thrombocytopenia. That is one of the important marker that this patient might bleed in the perioperative period. Okay.
Okay, sir.
Okay, so you check the prothrombin time and add vitamin K and fresh frozen plasma to these patients before you take them up, and you must have the prothrombin time or the INR, international normal ratio, in normal limits, right? Okay, all right.
And
Another
another thing is
Yeah.
another thing is, you see, now the recommendation has changed. Earlier, always used to stop clopidogrel, stop aspirin.
Yeah.
Now there are some recommendations in this therapy in the periodic period, because you see, the recommendation is, suppose a patient has got a valve replacement, and you cannot keep this patient off of this antiplatelet agents for 7 days. This patient is going to have a thrombus in the valve. So the recommendation has changed, and now the recommendation is, if the antiplatelet agents are essential, in that case you can continue with aspirin, stop clopidogrel. And the next point is, suppose patient is taking aspirin and others just for prophylactic reason. Patient does not have valvular disease or a gross coronary artery disease. Often people are given anti-platelet agent just for prophylaxis. In that case, you can stop. But if it is essential to continue, the recommendation is you can continue with aspirin, and nothing happens during the periodic period. Although you should be cautious that you should achieve good hemostasis. We can pass into Dr. Oma, who will present on the treatment of these disorders and the therapy available with us. Dr. Uma is a first year junior resident at SSKM Hospital. Dr. Uma, you can share your screen. Aditi, you stop sharing. Aditi, you please stop sharing your screen. Aditi, you please stop sharing. Wow. Dr. Uma, you're online?
Hello. Yes, sir.
Yeah. Aditi, you have to stop sharing. Aditi, can you hear us?
Yes, sir. I'm.
Yeah. Stop sharing so that Uma can share. Uma, you can share your screen now.
Yes, sir. Hello.
Please, yes, we can see your screen and
yes.
audible. Start, please.
Good morning, sir. I'm Uma, and here I'm going to talk on drugs affecting coagulation, bleeding, and thrombosis. First,
Uma, you are not audible. Uma, we cannot hear you. Check your audio. You are muted. Uma,
Oh.
you are muted.
Oh,
Yes,
okay,
yes.
okay, okay. First, starting with the coagulants, it is vitamin K, fibrinogen, desmopressin, adenochrome, ethamxylate. Vitamin K, it is a cofactor in the liver for our clotting factors 2, 7, 9, and 10. And it's a fat soluble from intestine via lymph and needs bile salt. The water soluble vitamin K, that is the menadione sodium bisulfite, menadione sodium diphosphate, they directly go into the portal circulation. And colonic bacteria also form the vitamin K for us, that is menaquinone K2, that is K2, 5200 microgram per day. So normally it does not produce the deficiency. And now the uses, we can use in the raised INR, which we usually do in the wards, and in obstructive jaundice in the newborn babies, overdose of oral anticoagulants. And the other drugs, that is fibrinogen, you use in the hemophilia, desmopressin in hemophilia, adenochrome in epistaxis hematuria, ethamxylate, which is having anti-hyaluronidase activity effect, used in hematuria, hematemesis, melena, epistaxis, PPH, menorrhagia, and it's having no action on fibrin formation. And the anticoagulants. In anticoagulants, we have heparin and vitamin K antagonists, out of which some of them can be given parenterally and some of them can be given orally. In parenteral ones, we have indirect thrombin inhibitors like heparin, low molecular weight heparin, and synthetic heparin derivatives like fondaparinux. These three have no intrinsic anticoagulant activity, rather they bind to the antithrombin 3 and accelerate the rate of it, and at which it inhibits the activated coagulation factors, that is factor 2A and factor 10A. And now the direct thrombin inhibitors like lipirudin, bivalirudin, and ergatroban. Ergatroban is excreted in bile, so it can be used in the renal impairment patients as well. These all are parenteral. Now the oral anticoagulants, that is the dicumarol, warfarin sodium, acinocumarol, and ethyl cumacetate. And these are coumarin derivatives. And another one that is phenindione, which is indadione derivative. The heparin can be given by IV route or subcut route, but not IM to avoid the hematoma. Low molecular weight heparin, that is enoxaparin, dalteparin, reviparin, they cause the less thrombocytopenia, and chances of hemorrhage are also less. So, and monitoring is not required as the response is very predictable. The synthetic heparin derivatives, there is fondaparinox and indraparinox. In the indraparinox is longer acting congener of the fondaparinox with once a week subcut dose in comparison to the fondaparinox, which is a OD dose. And these are preferred for prevention of venous thromboembolism in large surgeries. Now, the adverse effect of the anticoagulants, the adverse effect of heparin, that is heparin-induced thrombocytopenia, osteoporosis, and spontaneous fracture, transient alopecia, hypersensitivity. Adverse effect of warfarin are teratogenic. It causes hemorrhagic disorder in the fetal bone deformity, so it's contraindicated in pregnancy. It also causes transient alopecia, dermatitis, diarrhea. And contraindications of the anticoagulants is the bleeding disorder, thrombocytopenia, severe uncontrolled hypertension, GI disease with high risk of bleeding, threatened abortion, and concurrent use of aspirin or antiplatelet drugs. Now come to thrombolytics. We have streptokinase, urokinase, anti-streplase, and tissue plasminogen factors like LTplase, retiplase, and tenecteplase. The streptokinase, it's a streptococcal exotoxin by beta hemolytic streptococci group C. It acts by combining with the circulating plasminogen, liberating the plasmin, which breaks down the fibrin, and it forms a stable complex with the plasminogen, which then converts the uncomplex plasmin to active plasmin, which causes hydrolysis of the fibrin plugs. Now the uses, streptokinase we can use in the pulmonary embolism, peripheral arterial occlusion, venous thrombosis, lysis of coronary thrombosis in acute myocardial infarction, clear the occluded AV cannula. The contraindications, one thing that we have to cautious about, that the adverse effect, that is the anaphylaxis, especially adverse effect of the streptokinase, that is anaphylaxis, especially when we are using in the second time in the same patient. So not to be used if the patient has had previous streptokinase therapy in last 12 months. Now contraindications, surgery within 10 days, including any serious trauma or organ biopsy, serious GI bleed in last 3 months, hypertension, hemorrhagic disorder, or cerebrovascular accident. The fibrinolytic inhibitors, we have aminocaproic acid, tranexamic acid, phytomenadione, and aprotinin. The aminocaproic acid is chemically similar to amino acid, that is lysine, and it competitively inhibits the plasminogen activation. It uses bleeding from fibrinolytic therapy, any post-surgical bleeding, and can be given prophylaxis for rebleed from intracranial aneurysm, adjunctive therapy in hemophilia patients. The usual dose of aminocaproic acid is 6 grams 4 times a day, and if administered IV, 5 gram loading dose should be infused over 30 minutes. The tranexamic acid orally 15 milligram per kg as a loading dose, followed by 30 milligram per kg every 6 hours. The contraindications of it is DIC or genitourinary bleeding. And one thing I like to mention, that some other anticoagulants like the heparin, which we use every day to do the ABG, and the sodium citrate, which is present in the PTINR vials, and these are the in vitro to reduce the coagulability of the blood. That's it.
Yeah.
Thank you.
Okay. Dr. Big.
Yeah. So again, Uma, good presentation. Same thing for all the 3 speakers. Try to make it as applied as possible.
Yes.
In the sense that if you first speak of the disease where you are going to use heparin, then it is easy to understand why you're talking about the side effects or what are you talking about. So start with the clinical application. If you talk about tranexamic acid, try to talk first about the disease where you are probably using it, and then talk about, okay, this is how it works, and this is the other drugs that can be used, and these are the side effects. So just to say that everything is fine, knowledge is good, but if you start with clinical side and application, you will retain more, you will understand this subject more. Makunda, your comment.
Yeah. You talk of coagulants, you know that another important coagulant is you have in the market available the factors. You see, for hemophilia, we use factor 8 concentrate. You see, that is also a part of coagulant. Patient having hemophilia, apart from adjuncting therapy, a factor 8 concentrate is a very good therapy. So factor 8 and some other factors also available. Okay, you can use that. And second is, as I said, for us, DIC is a very important disease, consumptive coagulopathy. How do you treat consumptive coagulopathy? What is the treatment? The pathology is this. There is thrombotic episodes in different sides of the body, and that consumes the platelets, and patient has acquired bleeding problems. So what is the therapy for that? You have talked a lot of drugs. Diagnosis is by D-dimer assay and presence of high-grade degradation products in circulation. What therapy you start in patient who has got a diagnosed DIC? You have given the list of drugs. Which drug you should use? Uma?
Uma, you are muted. Please unmute yourself.
Yes.
Yeah. We talked about that. If you can diagnose DIC properly, the drug of choice is heparin. You can use unfractionated heparin, or you can use LMW. Okay, that will halt the thrombotic process and will halt the consumptive coagulopathy. Okay.
So Uma, again, start from the disease that we are worried about. If you start talking about DIC and then the treatment, and then you say heparin is the treatment, and then talk about how heparin works, which has already been said, and why LMWH and what are the advantages of LMWH or low molecular weight heparin, which causes the least bleeding. So what happens is it becomes a very clinically applied talk. So this is all, I think, is a very important point to understand. Similarly, if you're talking about, you didn't talk about cryoprecipitate. So we would be very happy to know about factor VIII cryoprecipitate. That's how we operate on patients. So start with the clinical problem.
Yeah. Even some disease like liver failure,
Yes.
you can correct this by giving the patient fresh frozen plasma. And if you have platelet disorders, you need to give the patient platelet concentrate infusion. Okay, so these all depends on the underlying clinical scenario which you are going to treat. You have given a good description of the drugs being used in our practice, but what Dr. Bega is trying to say is you could have make out that this is a disease and this is the underlying mechanism, and they should be treated by this particular drug. Okay, so this is a very basic part of hemostasis, where you have to know the basis of hemostasis, primary hemostasis, secondary hemostasis, and if you know this hemostatic mechanism, you know the disorders of this hemostatic mechanism, and you know how to correct this hemostasis. You see, if you have a platelet abnormality, you said you have talked about qualitative and quantitative. So if you have qualitative deficiency, that means the platelet is functioning improperly, improper function of the platelets. In that case, you have to think of replacing the particular substance which is being deficient, or you replace the patient with a normal functioning platelets. Okay, so that is a basic thing in therapy.
Yes.
Dr. Boshak, any comment? You will conclude. Dr. Shomindra Boshak. Boshak is muted. Okay, anybody, nobody has put a question. So we can conclude this program today.
Yes.
Okay. Thank you. Thank you, Dr. Beg.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you all the speakers. Well done. Congrats.
Thank you.
Thank you, sir.